Dr. Beachy is currently the Director of Behavioral Health at Community Health of Central Washington and leads a team of 7 BHCs. She is also a behavioral health faculty member at CHCW's Central Washington Family Medicine Residency and has duties working as a BHC there as well. She completed her pre- and postdoctoral training with leaders Kurt Strassel, Patty Robinson, and Jeff Ryder in both primary care behavioral health and acceptance and commitment therapy. Dr. Beachy has experience in training medical residents, medical students, and BHCs and PCBH, as well as ACT and Focused ACT, which is FACT, which this will be the topic of our conversation today. And additionally, she has co-authored 2 books, chapters addressing behavioral health in medical settings, and has given multiple presentations on integrated care both locally and nationally. Dr. Beachy is also an associate consultant of Mountain View Consulting Group and serves on the CFHA PCBH SIG leadership team. Dr. David Baumann, PsyD, is a behavioral health education director at Central Washington Family Medicine, where he also serves on the residency faculty and as a BHC. He completed formal training in the primary care behavioral health model and acceptance and commitment therapy during his pre- and postdoctoral experiences. His training supervisors have included both Jeff Ryder and Kurt Strassel, and he received formal training from Patty Robinson. Dr. Baumann has presented at a number of national conferences and authored book chapters on working with behavioral concerns in primary care. He currently serves as the leadership team of CFHA's PCBH SIG. He also serves as an associate consultant for Mountain View Consulting Group. And here is just a different plug for those two. They recently posted some really interesting interviews with Kurt Strassel on YouTube. I hope that you'll access those. It's an amazing way to catch up on the legacy and the history of PCBH. So I invite you to look at those, and that was just wonderful, David and Bridget, so just wanted to plug that for y'all. So it's all you all.
All right. Well, that was a nice introduction. I feel good about myself now. So we're going to go ahead and get started. We're going to go over the agenda really quick. We already completed the introductions, and then we're going to move into a brief overview of the PCBH model, a brief overview of ACT and FACT, as well as the philosophy behind a lot of these third-wave cognitive behavioral treatments of contextualism, and then why FACT and PCBH. How did they kind of, how are they married together, so to speak? And then how do we integrate FACT into our setting? So that's going to be the agenda for today. And I'm going to go ahead and pass the phone to Dave.
Yeah, so the one thing that we just always try to start out every presentation, specifically presentations that we're able to give that are on topics of, going through grad school. We've read a lot of, different things on PCBH and FACT and ACT, and then to be here today actually giving a presentation on both of those topics is kind of a surreal moment. So we're really happy that everybody's here. The one thing that we also want to say is that, we have that in there. After this presentation, you will know FACT. That's why we have the thing there, don't believe everything you think. This will definitely be more of an introduction to FACT and hopefully really just prompt and kind of ignite people's want to learn more about FACT, ACT, and then PCBH. And then at the end, we'll kind of give you some resources for you to be able to learn more about FACT and PCBH.
All right, and just to set the context and set the stage a little bit more, we did want to share what a day in the life of a CWFM BHC is like. So we, both Dave and I work at Central Washington Family Medicine. We average between 9 and 12 visits per day, and that's us as a team. So there's several other BHCs on the team, and nobody is seeing less than averaging 9 patients a day and up to 12 patients. We are in constant communication and collaboration with the medical docs, as well as the physician assistants, nurse practitioners. That's a really important part of what we do, is to be a part of the team. When we walk through the clinic, everybody knows who we are. They're not surprised to see us like, oh, well, what are you doing out of your wing? It is just, it's natural to be a part of the team. We do broad spectrum primary care at a clinic, so we're seeing kiddos all the way from when they're still in mom's womb all the way to late adulthood and people into their 90s. We see the full range of mental health conditions, depression, anxiety, all the way to medical conditions, diabetes management, high blood pressure, and then lots of things in between, lots of subclinical adjustment disorders, everything and anything you can think of, we see. I also want to point out that it's a training clinic, which is really awesome because it's constantly this environment where we're striving to learn more and to share that information with one another, so it's a very strong interprofessional atmosphere. We have family medicine residents. We have a whole plethora of medical students that come through our system, and then we have behavioral health interns. And these are, most of the time, they're professionals who are trying to learn more about PCBH. Maybe they've been, seasoned clinicians in a different setting, and they're trying to kind of get the flair of the primary care behavioral health model. And then also in 2017, we're going to be starting a pre-doctoral internship. So we always have somebody shadowing us. So just to give a quick overview of the PCBH model, the quote-unquote Bible of the PCBH model is Robinson and Reiter's 2016 version of their book. It's the second edition. The first edition was put out in 2007, and when we get to the end, we have the reference list. So you'll be able to see that. It's based off of the premise of population-based behavioral health delivery. So it's building off of having a strong primary care culture, because having a strong primary care culture has been linked to better health outcomes. So the idea is to meet patients where they're at, strengthen the primary care system, strengthen the primary care culture. So we model our service delivery after that through brief episodic care for patients that spans their lifetime. And like I said before, we're in constant communication with the medical team. So I did want to share the Trident approach to primary care behavioral health. This is something that myself, Dr. Baumann, and Dr. Jeff Reiter developed when we were trying to think about the full reach of primary care behavioral health, in that we're not just doing brief interventions and we're not just doing patient care. We're really trying to impact the whole system. So the very first one on here is doing direct clinical services. So that's seeing patients in this flexible 30 minutes or less format with trying to limit the follow-up, focusing on improving patients' quality of life versus only focusing on symptom reduction. We do group interventions, and we're really trying to address a broad range of behavioral concerns from a transdiagnostic approach. In addition to that, we just think that being there is a really important piece. Being in the medical culture is, as I was saying before, it really helps that interprofessional collaboration, and we can learn from one another. They learn from us, we learn from them, and it really gives a really good support for the biopsychosocial model. And that's a lot of the feedback that we get from our medical faculty is they're like, we're just happy you're here because we think about so much more of these psychosocial issues than we ever have before. So once again, getting behavioral health into the water, and then lastly, supporting the primary care system, because PCPs are so overwhelmed. So if we're able to see patients when they're running late, if we're able to see patients at follow-up instead of having the patient follow up with the PCP who's booked up, if we're able to take over, well, not take over, but come into a visit to allow the PCP to move on to their next patient, these are all things that support the primary care system. All right, and so that's kind of our overview of PCBH. We're going to really move into the focus, acceptance, commitment now.
So the other aspect of this is, as Bridget just said, alluded to, is that we're really going to try to talk about acceptance commitment therapy, and more specifically focus acceptance commitment therapy. So what we're going to do throughout this webinar, again, ACT and FACT are not going to be boiled down to 20 slides in a 40-minute webinar, but we're going to try to give little nuggets throughout to talk about the philosophy and really how we kind of approach FACT and ACT within the PCBH context. So acceptance and commitment therapy, as Bridget said, it's a third-wave cognitive behavioral therapy that incorporates behaviorism, meets kind of mindfulness and acceptance kind of philosophy, kind of Eastern philosophies. There's a lot of growing research support for those of you that are working in primary care, or just really, I think, especially mental health. You've probably been exposed to ACT in some context and know about the growing empirical support that it has for chronic pain, which has strong support designated by the APA Division 12, depression modest support, anxiety modest support. There was actually a great anxiety randomized controlled trial that happened, I think, a year or two ago that had a pretty decent-sized end, and it showed really good results for ACT when compared to CBT. And there's also growing research for its support when we look at kind of medical conditions or kind of things that are seen in kind of primary care, which might be smoking, diabetes, MS, weight loss. And the one thing, again, you can't boil down ACT into maybe one or two sentences, but the one thing that I think that always kind of reigns true, and when I'm trying to describe what ACT is, or the philosophy of contextualism, the philosophy of ACT, is that human suffering is ubiquitous. And the concern that really arises is that when the symptoms of human suffering, they're actually not the problem. The problem is actually our wants and desires to control these symptoms. As we go through a case kind of example, we'll talk a little bit more about that. But the idea that, depression and anxiety in and of itself, those aren't concerns. Those are actually natural human responses to usually pretty difficult situations. But when we try to control them, either through isolation, avoidance, substance use, that is when those behaviors that are trying to control and get rid of those symptoms, they start to become the problem. So if you're familiar with ACT, you'll be familiar with the Hexaflex. For those of you that are not familiar with ACT, I'm just going to give a brief overview of the Hexaflex. And the idea of ACT is really to promote this concept which is called psychological flexibility. And there's 6 core processes that contribute to psychological flexibility, and again, this makes up the Hexaflex. So that's contact with the present moment, or mindfulness, values, clarification, or identifying what you find most meaningful in your life, committed action to those values, selfless context, as being able to take perspective and viewing yourself as an individual and separate from your thoughts, which also leads into cognitive fusion, which is recognizing that thoughts and emotions are just those thoughts and emotions, that they're not you. And then the last one is acceptance, or willingness to engage in life even when uncomfortable thoughts and emotions kind of exist. A common, the one thing I did want to touch on real quick, regarding the Hexaflex, I think a lot of times ACT gets misconstrued as far as that you do these processes maybe in a sequential manner. Maybe you start with mindfulness, then you go to diffusion, and then you go to acceptance, and you maybe get to selfless context if you have time, and then you go to clarifying values and then committed action. It's a sequential process. It's really not. It's really a total experience that is more made up of psychological flexibility, and that's where I think FACT really tries to hammer that home and boil that down, and we'll talk a little bit more with that as we go along.
All right, so we're going to prime you all with a case, and this is going to come up again throughout the presentation, the case of Mike. So we're going to imagine that you're a BHC and you're getting a handoff, and Mike has been struggling lately. His wife recently divorced him after 10 years of marriage. Marriage struggles began after their son passed away suddenly 5 years ago. After the death of his son, he began experiencing depressive and anxiety symptoms such as sadness, heart palpitations, worry, mind racing, loss of interest. To combat these symptoms, he began staying home more, and drinking alcohol excessively, which ultimately ended in the demise of his marriage. So what I want you all to kind of think about and just take a few moments is what's Mike's problem here? What's going on with Mike? Are his depressive and anxiety symptoms, are they normal? Are they expected? If you were a BHC, what would you treat? Or if you were, a PCP, what would you treat? Would you treat his depression, his anxiety, his substance use, maybe his avoidance? So just kind of, if you're anywhere where you have a pen and pad, jot a few notes down, and just kind of keep Mike in the back of your mind.
And we'll continue on as you're kind of thinking about that, because, again, we'll reference back to Mike later on. But let's talk a little bit more about FACT, and particularly ACT, and the philosophy of contextualism. It's something that we'll kind of have as a theme throughout this webinar. When you're working within PCBH, there's not going to be one thing that you continuously always do. You're not just going to be always doing a CBT protocol for insomnia, or you're not going to always be doing motivational interviewing. You're going to take a mix of different things that are evidence-based and really to be able to apply it within the context of PCBH. So that's something I think we want to point out, is that every intervention that we do with patients is not going to be solely based on fact or act, but the philosophy of contextualism is going to reign supreme and reign true throughout our working with patients. So the idea of contextualism, again, contextualism has a lot of history, and it has, there's a lot more to just these 2 bullet points that make up contextualism, but the basic premise is that behaviors do not happen in vacuums. The idea of someone maybe that is kind of overweight and overeating and not exercising, those behaviors aren't just happening on and by themselves. There's something that's reinforcing those behaviors to happen. And so, again, having that idea that there's always a context to a situation, to behaviors, and that's something that we need to really assess, is those contexts for those behaviors.
Ultimately, there's a function to every behavior, and part of your job as a BHC is to find out, what is that purpose to their behavior? What is that function?
The other point that we like to point out, particularly when we're talking about fact and act and contextualism, is that relational frame theory, which is a really great growing science behind human cognitions and how kind of our mind really operates. And again, it's definitely a lot more complicated than the 2 bullet points and the 2 pictures that we have listed out here, but the basic premise being that our human minds are pretty awesome in what they can do, and that if we observe that A equals B, and then we also observe that B equals C, our mind can automatically derive that there has to be some sort of relationship between A and C, even though we never kind of observe that relationship actually happening. So again, if A equals B and B equals C, we can generally make that assumption that A then has to equal C, which is pretty beneficial. It's really helpful in our lives. However, when we start to put this into the context of kind of adverse childhood experiences, and something that we really try to really educate our residents and our medical teams on, and it's great to see the growing research, and I think also the growing awareness of ACEs. It really starts to build a picture of just how impactful ACEs can be. Again, if we go back to that equation of A equals B and then B equals C and then A and C have to equal each other, what does that mean for someone that experiences maybe a significant trauma or hardship in their life, which has then subsequently prompted anxiety? What happens is that our mind kind of cuts out that middleman. Instead of it just being you or experienced the trauma and that trauma promoted anxiety, it is you are anxiety or you are anxious.
Absolutely. I can't even say how many times in a given day where I meet with somebody and they say, I have no idea why I'm anxious. It happens completely out of the blue. And with a few questions, contextual questions about, okay, who do you live with, who's in your family, all of a sudden all this trauma starts pouring out, and it's like, well, you might not be really aware of why you're anxious, but I have some pretty good ideas of why you're anxious, and it's not for no reason, to put it that way.
So, it's tough to describe what fact is. Is it like a simplification of act, because it kind of boils it down to maybe a couple of visits and a couple of sessions, or maybe 1 to 3 visits, and where compared to act protocols it might be upwards of 12 to 16. We like to think it condenses act. It doesn't simplify act, because I would definitely say there's nothing simple about fact. And fact has really been born out of Kirk and Patty's work in primary care. Kathy did a great job kind of mentioning the PCBH corner that we did with Kirk, where we asked him a lot of questions and to develop kind of the history of PCBH. And the thing that he said that was awesome to hear was that his version of ACT has always been out of primary care, and that we had to have something that was transdiagnostic, that was going to be able to work quickly and really help people. And Stephen Hayes, who is one of the other kind of founders of ACT, he always kind of mentions that Kirk is the hands of ACT. Kirk is what really puts ACT into action. I think that FACT is really his and Patty's masterpiece. And the one thing that I like to look at FACT at, PCBH, as Bridget kind of said, is all about kind of population-based health. We try to take a little bit of intervention, we give it to a variety, or a large group of people, and hoping that those little interventions really ripple out into people's lives and grow exponentially. If that's a metaphor that we're going to use, I think the additional building on that metaphor is that FACT is going to be the most radical ripple. It has the chance to be the most growing or exponentially growing ripple in someone's life. And it's something that we really tell patients every single time when they come and meet with us, is that, giving that expectation that it might only take 1 to 2 visits to see kind of some positive change, or to see some movement towards these life values, and to see maybe a radical ripple start to grow. And it's something that Kirk also kind of mentioned to us, when we go back to that case presentation of Mike, who was, starting to isolate and to use substances, maybe that's what shows up at 5 p.m. is his kind of isolation and him abusing substances, and we could definitely intervene at that point. I think that would be an appropriate intervention, and that wouldn't be a wrong intervention by any means, and that could create a ripple in his life. But if we actually swim upstream and start to deal with what happens when he wakes up at 8 a.m., which is that he has to deal with the fact and the human suffering piece of, I lost my son, and that is very difficult to deal with, and dealing with those emotions and those uncomfortable thoughts and experiences. If we can deal with that, that can really be, again, that radical change. And what we kind of have that philosophy, again, is what prevents a vital life is our want to be symptom-free, and it's something that it can be a really big psychoeducation piece and, again, promote that radical ripple. So
with FACT, it is condensing the Hexaflex that we had up earlier into 3 pillars, into open, aware, and engaged. And there we go. We have it kind of over, so you can see the Hexaflex in the background, and then the pillars. So once again, as Dave was saying, it's condensing it. It doesn't necessarily always simplify it. But that awareness piece is absolutely so important. The awareness piece is right down the middle. That's that contact with that present moment and the ability to have perspective-taking skills. And so when we're meeting with somebody, a lot of times we have to start with the aware. We're asking questions about what's going on in their life. You know, what's your family situation? Are you in a relationship? And a lot of times patients will want to launch into their stories. And it's almost like these stories are on replay. And it's almost like they're time traveling. You know, they're going back in time. Well, you know, what happened was when I was 3, and then this happened, and this happened. And it's not that I don't want to hear the story per se. It's that they're not really there. It's just kind of on replay. So what we want to do is do an interview in which we are bringing them into the present moment. We're noticing some of the thoughts, some of the emotions, some of the sensations that they might be feeling right then and there, and pointing that out. So you can continue on your interview. We don't have to stop everything and say, oh, well, what are you feeling, what's coming up? But we can do little bits and pieces of that to really bring somebody into the room with us. And then the other, you know, as we shift more into the open section, the open pillar, that's the acceptance pillar, the willingness pillar. The cognitive diffusion, which is, as Dave was saying, is where, you know, you aren't your thoughts. We have thoughts, but you aren't your thoughts. And we don't have to act upon literally every single thing that we think of. And this is where we both try and infuse a lot of humor into our visits. I'll give the example with patients like, you know, have you ever been cut off when you're driving in traffic? And they're like, yeah. And I was like, well, what's your automatic reaction? You know, isn't it to kind of like run them off the road? And they're like, you know, kind of sheepishly say, well, yeah. I go, well, do you do it? And they go, no. I was like, well, that's an example of you having a certain thought or feeling and not acting upon it. And this happens all the time where we can have certain thoughts and feelings and not act upon it. So we're trying to get the patient to realize that we have these thoughts, we have these emotions, and sometimes it happens without our control. It just kind of shows up. And that's the type of language that we use is, you know, what's showing up for you. And then lastly is the engaged pillar. And this is really kind of where you can hit that that pragmatic behavioral piece, because identifying what somebody finds to be important in their life, aka their values, and then coming up with a behavior plan that links to it, that's nothing new to ACT. You can see that through tons of different therapy styles and interventions. And that's very tangible. So if somebody does say, hey, parenting is the most important thing to me in my life, well, can we link some type of behavior such as walking your kids to school, even though you don't really like leaving the house because your anxiety shows up, but can you bring that anxiety with you as you walk your kids to school, because being there for them is the most, you know, important thing for you. So so that's kind of would be an example of how we might move through the pillars.
So one thing that I'll also kind of point out with this, and is that similar to the Hexaflex, as we said, you know, there's not this, you know, you do mindfulness, and then you move to cognitive fusion, you move to acceptance. There's not this sequential part of the 3 pillars. It's not, you know, sequentially going through them. However, we do definitely, and this is something Bridget will talk a little bit more about, and she actually did just talk about that, is that we do see some patterns and some useful maybe starting points for people.
If you're getting your you do your interview with the patient to understand their context, and you're really kind of hearing what symptoms are coming up and then what those symptoms are preventing them from doing. And if you get stuck as a BHC and you're like, well, I'm not really sure where to go next, you never can go wrong by going middle. And this is what Dr. Strassel says all the time. He's like, go middle. And that's going into that awareness piece. And once you kind of have that person where they're there with you, then you can move left. You go left, which is the open pillar. And then as you're able to get some of that, some flexibility going in that, then you can make your plan, the behavioral plan, more the pragmatic behavioral plan that I was talking about. So go middle if you're not really sure. As you get that developed, you go left. And then once you get the left going, which is the open pillar, then you can move to that engage pillar. A lot of times, docs, and no offense to docs, they're a little bit, more fixer mentality, but BHCs, we have a fixer mentality too, and we want to really get right in there, and we want to fix and say, okay, well, what can you do right now to become more engaged in your life? But really, sometimes what stops somebody from being engaged in their life is all of these different thoughts that show up, like Dave was saying, in the beginning of the day, and they end up getting bullied by their own thoughts, by their own emotions, and really that's where we can intervene at. Because if we skip that part and go right to committed action and values, we really might be missing a really important piece to what's going on.
So hopefully we've been able to set the stage a little bit about what FACT is, and now we're going to try to really incorporate of how we kind of do FACT and PCBH and a protocol. So let me say, it's always an interesting kind of moment where you think you've got something, you think you have a great understanding of what something is, and then you get kind of smacked down very quickly. It's like you have no idea what you're kind of talking about. And this has happened numerous times, particularly with PCBH and ACT and FACT, and I'm sure it's going to continue to happen throughout my life, so it's something that I need to accept and have a willingness to continue on with. And why I'm saying that story is that again, we had a great training in our doctor program that exposed us early on to PCBH. We had practice rotations. We did our dissertations in the PCBH model. We go to HealthPoint in our internship, and we're doing PCBH. We feel like we're getting it. We're talking to Jeff about different things, and we have great supervisors at HealthPoint, and it was really going great. And then we come for our fellowship. We're real excited because we're with Kirk, the guy that really kind of started the first ripple of PCBH, and he kind of goes into this contextual interview kind of idea, or this contextualism. And man, did we fight like hell to make sure that we just didn't think it was possible to do, and we're going to go into what the contextual interview is specifically. But this is kind of the protocol that we have. And I tell you what, after about 2 to 3 months, it was amazing to see our transformations of like, wow, this contextual interview in and of itself is fact. When we go back to this slide about being aware, in the contextual interview that asks specific questions, and again, we'll show you what these questions are, it allows people to actually get into that first pillar or that middle pillar of aware. And then it actually allows, I think, people to start to identify and open to these other kind of concepts as willingness and cognitive fusion. And then lastly, I think it really ends up and identifies people's values. So the contextual interview in of itself is a very kind of, I think, good description of just the 3 pillars in action. And those contextual interviews broke down into love, work, play, and health behaviors. And let me say this, we do this every single time we see a patient. New patient, I should say. Every single time we get a handoff, we do the contextual interview. We teach our residents to do the contextual interview. We are definitely on the contextual interview bandwagon. I think for the obvious reasons of what we said before, is that you can try to intervene on a specific behavior, but if you don't have the context for that behavior, it is not going to be an effective intervention. So the contextual interview takes us about 10 to 15 minutes, and again, this is every initial visit that we have. We do the contextual interview for about 10 to 15 minutes. It's interesting because our residents a lot of times fight us on doing the contextual interview, and they say, one, it's like, oh, this is just a psychosocial intake that we've been trained to do, or two, we don't have time to do this. So when we do role plays, we time them, and it's like, hey, you know what, actually, how long do you think that took you? And they say, oh, it took about 14 minutes. It's like, well, no, it actually only took 8. And so it's something that you can get a lot of information in a short amount of time. And we had a resident just this past year that would say, it's amazing that she's like, I thought I understood kind of the psychosocial kind of intake. I was taught to do this and to check on these different kind of factors, this contextual interview is just something different. It's something that gets you so much more information. So 10 to 15 minutes is spent doing the contextual interview, and then that follows about a 2 to 3 minutes of contextual summary that we get back to the patient to make sure that the patient, we're on the same page and we're understanding what the patient had said during our interview. And then we do the 5 to 10 minutes of an intervention. Now, as I said before, again, it might not be a specific act, fact, metaphor. It might not be a specific kind of intervention that is done that's related to act. In fact, it might be basic sleep hygiene for someone that's having insomnia. However, I would say more often than not, we're doing an act, fact, a specific metaphor, and we're going to get into the metaphors in a little bit. But the contextual philosophy, regardless of what we do, our interventions are undoubtedly always going to have a behavioral focus, but our contextual philosophy is going to remain throughout our entire interview and then also through our entire intervention.
And here is our contextual interview. It's love, work, play, health behaviors, and the 3 T's. So the love is starting out asking somebody what their living situation is. We always want to know who's in the home, especially for older folks, especially for people with chronic medical conditions, and for kids. But this goes for everybody. And then from there, you learn so much, because who people live with oftentimes gives you a glimpse about their relationship and their family. But if you didn't get that information from asking about the living situation, you do have to follow up on that. So at the end of it, we're going to want to know what the living situation is, what their romantic relationship, family support, friends, if they have a spiritual/community life, and then we're going to want to know how they get an income. So this should actually be work/income/school. But knowing, are they working? Is it Social Security? Are they going back to school? Are they retired? We want to know that. And then play. What do they do for hobbies? What do they do for fun? And we tell our residents, like, you can ask somebody if they're having anhedonia, or you can ask them what they like to do, and if somebody isn't able to readily identify something they like to do and get joy out of, then you're pretty sure that they hit that anhedonia for depression. So asking somebody what they do to nurture themselves is a really important question. And then we move into health behaviors. So we're going to want to know their exercise, sleep, substance use, so alcohol, drugs, cigarettes, caffeine. Sex is one that we almost always touch on, especially when we're talking about teenagers, but it's not 100%, especially if we kind of know the relationship situation. And then we're going to want to know what the type of diet that they're eating. So we're trying to, in the PCBH model, is marry the way it should be, physiological and medical to psychosocial, because they are inextricably intertwined. You can't have one without the other. And then we move into the 3 T's, and if somebody's presenting for anxiety, or once you do your contextual interview and it turns out, yes, they're dealing with anxiety symptoms, we're going to want to know the time, as in when was the onset. Is this something that's new, or have you had this for as long as you can remember? Because those 2 things are going to get us something different. We want to know what some triggers are, and then we want to know how this has been over the course of their lifetime. Have there been times where things were better or things were worse? And that's that trajectory piece.
So a couple additional comments that I have about this contextual interview is, one, when we first got exposed to this, we said to ourselves, there's no way we're going to be able to get all this information within a 15 to 25-minute PCBH visit. I mean, heck, this is going to take at least 20 minutes to gather all this information, and then we're supposed to intervene on what the PCP is kind of requesting us to go in for. So again, we had those doubts, and as I said, it probably took us a good 3 months of Kirk really beating it over the head and saying, you don't have a choice, you're doing this. And we're so appreciative that that's what he did, because we were able to figure out a way, and this is through practice and through timing and getting used to it. We ask the questions the same way every time. We go through the process the same way every time. This is, as a kind of Bridget really likes to point out with our residents, this is essentially a procedure that you're doing with patients, that you are doing it the same way that you would be doing if there was another procedure that would be related to a medical concern in the clinic, that you do the same way and you kind of have this process to go through it. This isn't just us sitting down and asking random questions. There's a structure to it. There's a purpose to it. And this isn't also just a checklist that you're doing. Instead of a checklist, we try to frame it as you're building a story. You're building this person's life context. If there's a chapter of that story that you're just kind of figuring out, like, man, that just doesn't make sense. I'm missing a piece. You need to go back and ask about that piece and be able to check in on that story. You know, the one example that I can say, and we have numerous examples of this happening, but the one example that I'll point out is I had a resident about a month ago. There was we were huddling and scrubbing their schedules, and scrubbing the resident's schedule just means that we look at all the patients that are coming in the day and kind of identifying patients that might need a warm handoff. And there was a 16-year-old that was coming in for stomach pains. And I have a rule of thumb that if it's under 35 years and there's any kind of headaches or stomach issues, that it's probably going to be a behavioral health consult needed. And so I identified this patient, we talked about it, and the patient showed up, and it was about 4 o'clock, and the resident, I ran into him, I was like, hey, how about that patient? He's like, you know what, I'm not sure what's going on. I really don't know what the stomach pains are concerned by. And I asked him, I said, well, is there anything going on in the patient's life? And he's like, I'm not really sure, I don't think so. I was like, well, I'll just hop in and kind of see. The amount of information that I was able to gain within the first 3 minutes was able to very quickly identify where the patient's stomach pains were coming from and the context that was going on. So, again, it's something that can be so beneficial. And like Kirk always says, and he always drilled this into us, is that the problem that might be on the surface has nothing to do with actually what's going on with the person. And actually, you know, this weight concern, again, we can do a great behavioral intervention for weights, but unless we have that, what's the context of what's reinforcing that weight concern, that weight's not going to change. So this really kind of opens it up. And again, it takes away that, I think, that misconception or misperception of what PCBH is, that it's superficial, that it's only surface level. And this makes PCBH anything but superficial.
Absolutely. And it does, I will say, it does take a lot of practice to get the pace down, and that's the other thing that Dr. Strauss always says, is if you win the pace, if you win the pace, you win the race. So it is very directive, but it doesn't take away the rapport, because then that's another thing that people worry about is, well, if I'm taking them through this interview, is that going to diminish the rapport? And it doesn't, but it does take a lot of practice. So we have a list of metaphors for the different pillars, and actually I'm going to have Dave explain, because he's made a couple of these really good metaphors, and I've been stealing them in my clinic, and it's been going really well.
So a couple of different metaphors, and we wanted to give these for you because, again, like we said, you're not going to be able to go from this webinar and probably very few things can you do in 1 hour webinar and be like, you know what, I got it, I'm going out there, I'm going to do it. But we wanted to give you some kind of our interventions, particularly, you know, ACT is kind of synonymous with using metaphors and doing a kind of experiential exercises to really hammer in points. So there's a couple that we wanted to highlight, particularly with the open section, which, again, open is talking about the acceptance and diffusion part. And the acceptance piece, the one that I always like to use, the story of the 3 little pigs. And, you know, I think everybody kind of knows that story, and that's why I try to use it, because people can relate to it. I did have one person say they didn't know the 3 little pigs, and the metaphor didn't work as well. But so, again, the story of the 3 little pigs, you got the first little pig that he's kind of builds a house of straw, and the wolf comes, huffs and puffs and blows it down, and he runs over to the second little pig's house. It's a house full of sticks. The wolf goes, huffs and puffs and blows it down, and they finally run over to the third little pig's house. It's his house of brick. It's a fortress. Wolf comes, he can't blow it down, and the story kind of ends, right? The story kind of ends that the pigs are safe inside and everything's grand and great, and it stops. The problem, though, with that story is that it's really incomplete, in that while the pigs are safe on the inside, while the pigs are safe in their house, that wolf is still outside. And for those pigs to have any kind of life, any kind of movement towards the things that are important to them, they got to take a step outside of that house and still face that wolf. So this is where a lot of things like anxiety, a lot of things like depression really come into the point that we look at depression and anxiety, it's like that wolf. These uncomfortable thoughts and emotions and these experiences, we build up things, we kind of protect ourselves. Maybe that is using substances. Maybe that's using kind of isolating and disengaging from life activities, kind of actually literally staying in the house. And all while that wolf's still outside patrolling. And for us to have any kind of opportunity to kind of engage in a meaningful life, we have to allow the thing that we're most afraid of to potentially enter into our home and for us to be able to go out. The other metaphor, did you have anything? No. The other metaphor that I like to use for diffusion, and again, diffusion is the idea to really be able to recognize that you're thinking, or you have thoughts. And in diffusion also, this driving a car exercise also goes into kind of the awareness piece, being in the present moment. But the GPS system is that, if you can imagine yourself driving a car, and usually nowadays we have like a GPS system, either it's our phones or like a TomTom that's in our front, right on our kind of next to our steering wheel, and then we have the rear view mirror. If we can imagine that our mind is kind of like driving a car, and that when we think about the past, it's us being kind of looking out or looking in our rear view mirror. And if we think about the future, it's about us, or predicting, it's us kind of looking at the GPS system. And they're both very useful things, for our minds to do, and both very useful things for ourselves to do when we're driving. We want to be able to look at the past traffic and oncoming traffic. We also want to be able to know where we're going. But the problem is what would happen if we would get solely stuck in only looking in the rearview mirror or looking only at the GPS system? What if we forgot that we were actually driving the car? Well, what would happen is that we would wreck. And this is a thing that really helps with people that have kind of racing minds, that maybe are looking into the past too much or thinking about the future too much, is to come present moment, one, to notice that that's your mind pulling you into these different things, into the rearview mirror, to the GPS, but to be able to then kind of come back and actually drive the car and be in that present moment.
And in that moment, we do teach them skills of naming 3 objects that they see, naming 3 things that they smell, and 3 things they can touch, to kind of literally bring them into the present moment. Sometimes just the process of being aware of, oh, wow, I am in the future, literally just that can be enough to bring somebody back into the present moment. We have some more metaphors on here. And like I said before, I've been stealing a lot of Dave's metaphors. He's very good at that. And I mean, normally I say I'm better at things in general than him, but he really has the metaphors down. So I actually literally used the self as context metaphor yesterday of watching your life on a movie screen. So I'm sitting with a patient, and this is only the second time I've seen her. The first time I saw her was about diet and exercise. I knew there was more stuff below the surface, but she really wasn't having it, so that was okay. I took what was given to me. And then the second time she shows up yesterday, and I haven't seen her in a few months, so I start, asking some questions about the contextual interview, and all this trauma just starts flooding out, and I'm like, wow, okay. And she is seen at she's a psychiatric nurse practitioner, and she wasn't able to get a hold of her, and then she was considering going to the ER, but instead she decided to come into primary care, asked for me, got on my schedule. So as she's talking, she's kind of calming down, actually. And she's like, I just don't know what's wrong with me that I feel this way. And I was like, I'm sitting there thinking like, well, it's very clear to me why you're feeling the way you're feeling. You've been through a lot of things. But of course, I'm patient, and I'm just like, okay, well, how am I going to get, I know that this woman needs to have some compassion, but how am I going to get that? So I'm like, okay, Dave's wonderful movie screen metaphor. So I was like, all right, what I want you to do is just kind of imagine from the time, and I walked her through all the things that she had told me. Okay, when you were 3 and this happened, and when you were 10 and this happened. And I was like, I want to imagine that you're the character and we're watching this on a projector, we're watching a movie of your own character. And now fast forward to, she's in her 60s, being in your 60s, what do you feel for that character? She turns and looks at me. I literally wish there was like cameras there, because it was just so perfect. It doesn't always go perfectly in PCBH. Anyone who works in this knows it doesn't always go perfectly. She says, oh my gosh, I have compassion. And she used the word compassion. So I was just like, ding, ding, ding. I literally think I said ding, ding, ding. I was like, yes, you would have compassion for that character. So, you would have compassion for yourself ultimately. She's like, yeah, I never looked at it like that. I always just kind of felt like there was something wrong with me. And my boyfriend, he might leave me because there's something wrong with me. She's like, but really I have compassion. I was like, yes. So what to do about this? What we can do about this is just ask your boyfriend, to be there with you. He doesn't have to fix anything, just be there with you. And she's like, yeah, I need to just cry and let it out. And I was like, man, I really wish that there was cameras, because it was just a picture-perfect visit. And like I said, it doesn't always go like that. But it was just an amazing moment where she couldn't see it in herself, but when she imagined herself as a character, she was able to do that perspective taking and develop that compassion.
And I think this, the selfless context one, I think is one of the processes in ACT that really gets overlooked because it's a difficult one to explain. It's really kind of a very twisty, kind of a lot of different layers to it, and it's a difficult one, particularly when you're trying to use language to explain. It almost never works if you just kind of try to explain selfless context without using a metaphor. But the one thing that Bridget just said, and this is where, again, I won't go off in too much of a tangent here. If we talk again about ripples, if we talk again about these things that are going to have radical change, if anybody's ever been reading up on the kind of new research that's coming out about compassion and really showing kindness to yourself, I tell you what, it is powerful things. And I think this is where the selfless context really sets up that opportunity to grow that compassion into people. And the thing that you got to remember, again, and this is where, ACT differs a little bit from CBT in a lot of ways, that doing self-affirmation, saying I love myself or saying I'm going to show compassion to myself today, usually based on the principles of RFT, what usually shows up afterwards is, no, I don't love myself. No, I'm not compassionate towards myself. So kind of trying to force yourself or wrestle yourself into believing, hey, love yourself, a lot of times it does the opposite. So this is where we really have to do behaviors. We have to do things to really demonstrate and to show compassion towards yourself and to build that up. And again, this is where the selfless context really bodes well for doing those kinds of interventions. So the last kind of, again, some metaphors, and, I obviously go back, and these are metaphors that are well known in the ACT community or the FACT community too, and they have scripts for them. It's a lot of great and different metaphors to use. Again, if you can, the thing that, Bridget had mentioned, that we try to come up with our own metaphors, I tell you what, there's nothing more powerful to be able to kind of work with someone's story and then develop a metaphor using their story, because people can really buy into that. So just the committed action kind of points of, there's a person in the ocean metaphor, there's a bullseye action steps. We won't go into these specifically, but look these up, and they're really great metaphors. I don't know if you have anything else you wanted to add.
Yeah, I mean, if you look into the ACT literature and look at a lot of the resources, you'll see Passengers on a Bus, you'll see Retirement Party in the FACT books, and the Real Behavior Change book by Strassel, Gould, and Robinson. You'll see the bullseyes, and those are wonderful. But like Dave was saying, the highlight of it is being able to use a patient's story based on their interests, if they're really into horseback riding, and being able to create a metaphor from there. A lot of times that could be really helpful. So I want to, we're wrapping up, and I know that we're at 9:53 right now, but I wanted to go back to that case example of Mike. So, based on what we've talked about with the context and kind of understanding Mike's symptoms, that they're not just happening in a vacuum. He's not just staying home and drinking and being depressed about his marriage. He's struggling with a lot of different thoughts and emotions that show up. So, I don't know if we can do into the chat box or whatnot to figure out what Mike's problems are. To share that.
The one thing, again, I would say in this, and I think this is where I love PCBH, because there's so much flexibility, and this is something we tell our residents, because our residents always ask, well, how do you know what to intervene on? Like, how do you know which thing to kind of approach? The nice thing about PCBH is that, again, since we're kind of doing this population-based kind of philosophy, and that we're not, again, I don't say this lightly, we're not trying to heal people, because, again, I don't think people need healing, and we don't need to make people symptom-free. There's a lot of different things that we can intervene on. So I think in this kind of case, if we're looking at the things to kind of intervene on, obviously, maybe getting them out more, doing some behavior activation plans, and maybe cutting down on the alcohol use would be a great place to intervene. I think that would be appropriate. The thing that we always kind of do is, like, what is the thing that's happening, though, at 8 a.m.? Let's swim upstream and maybe deal with some of these uncomfortable thoughts and emotions, and maybe we can do some metaphors and some different kind of exposures and experiential exercises to really get at that.
Yeah, and so you could do with this case about what Mike's problem is. Mike's problem could be that he's depressed. And like Dave said, we got to get him behavioral activated. We have to get him going to work and doing enjoyable activities. We'd have to ask him, what do you like to do? Maybe he likes to play basketball, so let's get him back playing basketball. That's totally an appropriate intervention. Maybe he wants to cut back on his alcohol, or maybe he's considering going to AA meetings. And going to AA meetings may be something that we want to do, or maybe a support group for his marriage ending, or maybe if he's religious, getting him to go back, maybe he hasn't been to church, getting him to go back to church. Those would all be in the realm of behavioral possibilities that we can do. I personally, am at the point where I would want Mike to see that there's a lot more going on than him just being sad. There's a lot of things that happened. It makes sense to me. I don't know how many times in a given day I say that sentence or that phrase. It makes sense that you're feeling the way you do. And kind of pointing out to him, like, depression and anxiety, yes, this is uncomfortable, but that's not the problem. What we need to do is have you re-engage in life. And how can we do that? How can we get you re-engaged in life? What's important to you? And I don't know what is going to happen with Mike, but if I do my contextual interview on Mike, a lot of stuff is going to come out, and I really get to pick between, I don't know, it could be 10, 20, 30 different things that we can do. And if you do the contextual interview and use it as a tool, honestly, a lot of the interventions fall into your lap. By the time you get to the intervention piece, you know what you need to do because you've properly assessed the context. So it could be using different metaphors about, hey, we can't control the sadness, leaves on the stream, clouds in the sky. You can use some of those metaphors. Or it could be something a little bit more tangible. It really honestly depends upon what Mike's giving us.
And the one thing that Bridget said, and that we can maybe end on here, is that it all starts with the context, though. And unless we get that context into the contextual interview, and I think that's the biggest thing, if we have a take-home message from this webinar, is one, just the philosophy of contextual and the philosophy of fact and act and kind of moving people towards this valued life. But the other thing is that we can use these contextual interviews, as Bridget just said, as an intervention, and it's something that we can do within PCBH. It goes against our PCBH qualities. If anything, I think it just really enhances what we're trying to do within PCBH. So,
yeah, and also in summary, people are not broken. There's a function to their behaviors, and if you can kind of get at that function, it can be very, very powerful, and that's the message. To normalize, to validate, to be there, to understand things in context, that is what can be life-changing. So the resources that we have is the Brief Interventions for Radical Change, Principles and Practice of Focused Acceptance, Focused in Acceptance Commitment Therapy, and that's Strassel, Robinson, and Gustafson. Then there's some YouTube clips, Fact in Action. And then we have people shadowing us and coming out to our clinic all the time at Central Washington Family Medicine. Email us. That's absolutely something that happens all the time.
Another thing I would say is that the YouTube page, obviously since this is a webinar, if you can't kind of click on that YouTube page, if you just search my name, David Baumann, my channel will come up, and there's a lot of different information on there, particular sessions and demonstrating the 3 pillars, and we also have a lot of great PCBH things with that as well.
And it's actually David Baumann, PsyD, because David Baumann's actually pretty common. So if you do David Baumann, PsyD in YouTube, he will come right up.
Any other questions? As again, we have our kind of a reference list. These are always great references and great readings to use. So if there's anything else or other questions, we would love to take questions right now.
Yeah, thank you, Dr. Baumann and Dr. Beatty. It's been a terrific webinar today. Again, we've got 1 or 2 quick minutes left. If anyone has any questions that they would like to type into the question box and or raise their hand and ask verbally. Again, we'd like to thank our speakers and remind everyone about our upcoming conference in Charlotte, just 1 month away. Please feel free to log on to the webinar or log on to our website. We do have, David and Bridget, one question, the role of formal mental health diagnosis. Somebody's asking about the role of a formal mental health diagnosis.
So, yeah, that's a good question.
Maybe I should.
Well, I won't.
Okay. I don't know. I think we should censor Dave right now.
I'll start out for this. So, in PCBH, I will say that I think in the PCBH philosophy, but definitely in the ACT-FACT philosophy, the role of the kind of mental health diagnosis is it goes as far as how helpful it is going to be for our interventions. And since in my kind of experience in the research that I've done, being able to get to an accurate diagnosis does not a lot of times change the way that I'm going to work with a patient. So that being said, though, I think it can be very useful for kind of as the medication management, particularly if someone is kind of distinguished as this bipolar or this depression. I think that's something that we can definitely do. And the other thing is that, and this is what we tell our residents, is if you do a contextual interview, as Bridget was saying before, a lot of times you're able to get the symptoms that you need from the DSM-5 to make this kind of classification of the disorder. But again, in our context, I'm less really concerned about mental health diagnosing just because my interventions are not necessarily going to change in a lot of ways regardless of what the diagnosis is.
Yeah, hence the trans diagnostic piece. And in PCBH, you have to be ready for whatever steps through the door, and so you can't you just can't switch from different intervention or from different philosophy to different philosophy. So having that transdiagnostic approach is extremely useful. And then I would also say diagnosis can be useful from communicating, communicating among different providers and whatnot. But when I communicate back to a PCP, I rarely lead with they have major depressive disorder, recurrent, moderate episode. I lead with the contextual pieces.
And I'll add on this last point about this. I think, especially in the medical clinics, there's a big focus on sometimes mental health diagnosis. And the Association for Behavioral Cognitive Therapies put out a great special edition last October 2015, and if you Google it, you can find access to it, on kind of the chemical imbalance kind of realities or lack thereof related to the mental health kind of pathologies. And I think this is something, when we talk about the Trident approach, where we can really do a great job of kind of educating medical providers who usually get maybe just one class that might be a variety of different topics on psychiatric kind of diagnosing and prescribing, but they're the ones doing the vast majority of these prescribing and diagnosing. So I think it's something that we can really help with in educating and using the science that we have, up-to-date science regarding mental health. Oh, time's up. Sorry, Polly. Okay.
Oh, no worries. Thank you guys for that presentation today. It was fabulous, and thank you to the audience for joining us. Recording of this webinar will be on our website in just a few days. Thanks again.